So I just want to give you a little background of how we function inside CDHP. And we did a deep dive and really start with our why. We're deep into Simon Sinek, if you want to go there. And that we see ourselves not as a dental organization, like Bert said, but really as a place to improve the opportunities for families. We have started moving sort of the work that we do of talking about family success and how opportunities for families are built from oral health also, and that we are beginning to see oral health really as a driver of inequities. Without addressing oral health, we are persistently putting families at a disadvantage instead of trying to pull them, give them opportunities to make changes. So we do this through some really clear goals, and I think these goals are not different than what we've done in the last 20 years, but we're just framing them slightly differently. So our clear goals are integrating oral health into systems where families live, learn, and work. Our goals are also include that race, income, and geography are not barriers to oral health, and that better oral health is about quality of life as a driver. I don't know where this goes. Here's our operating principles for how we decide what we're working on and which policies, because even though we think of ourselves not as a dental organization, many on the Hill still think of us partially as a dental organization. And so because we're the voice of oral health on the Hill or with a lot of partners, regardless of the issue, we get called. Before there was a strong coalition of Medicare, I was actually just going through voicemails. Bert has tried to call me, and a couple of other people tried to call me, and my voicemails were completely full. So I started going through them and emptying them. And I was listening to a 2017 message that somebody said, "Hey, this is so-and-so from Capitol Hill. I was just wondering who you would refer us to for Medicare issues on oral health." And I was like, I wonder why I saved that message. I wonder who I sent them to. I wonder if we answered a question or who I sent them to. But we get called, and so there are times where we have to decide how to stay focused. And we start with the evidence. Where do we have solutions to provide? Because we want to build policy. And I think how we function different is that we really start with the evidence and build a policy. We do the advocacy, we try to get the policy in place, and then we support implementation, and then we evaluate. Think of it as a PDSA cycle for those of you that do quality improvement, is that we're constantly looking at what is the problem, what is the policy, how do we advocate, how do we implement, and I mean implement at the federal level, at the state level, how do we help local partners and providers, and then how do we evaluate whether that worked or not, and do we need to make fixes again? And I'll go through an example of some of the places where we have already started looking at new legislative fixes to policies that we put in place. And I could go through a million of how we got things right and how we have unintended consequences to some of our work. Persistence. I think we're always at the table. We're here, right? We're not a Medicare group, but we're here. We're at all sorts of tables that put us in light of trying to get into more family success. How do we sit at the table with those that are working on racial justice issues, on economic justice issues, that are working on early childhood development? How do we start talking to them and coming to the table and saying, we have something to offer you. We have something that can help your program work better, because this is actually a huge barrier to families that I know you don't think about. It's never going to be your top priority, but we can help you succeed. So we need to be at the table. We have partnerships. All of you in the room are partners at different levels of the work we've done. And our philosophy is that we take as much as we give. So we have to be able to provide, I'm staring at Patrick. Poor Patrick sat right in the middle in my view. Families USA is a great example. There are things that we do with them and with other partners that we wouldn't necessarily do because it's driving our mission, but because they need our sign-on, so we have, a large list of groups to show that their support across the broad span. The same is that we need them, and that's true for a lot of different issues. So we have to give as much as we take. And then the last one is that our mission is first. I think there are a lot of issues that we've worked on that people probably have no idea that we were behind. And that's because we haven't worried as much about taking credit for the work because the mission comes first. And that's hard for a lot of groups in this town. think it makes us unique in some ways, but it gets the work done. So our tactics. I think the framing, the hooks, the drivers, and the targets, and the visibility are pretty, sort of standard ways in which sort of policy and advocacy works. And I just want to give you a sense of how we do that. Family success is our endpoint. I think we've really changed our thinking recently of not talking about the disparities in oral health and talking more about family success. And I think oral health is not our end game. Oral health is a means to an end. And the end is that families have options, and that families have choices, and that families have ways to get out of poverty. And so that is our end game. And to be able to go to somebody and say, oral health is a means to that end. How can we help you? How can you help us? Our hooks are really bi-directional. We're doing more and more research on the connection between oral health and outcomes, and that's health outcomes, education, employment. How do people function in society? It's not just by oral health, it's by these relationships between parents and children and how that impacts their health and the parents' employment. How does it impact sort of those employers or the education system? It's bi-directional and between both the issues and the populations. We choose, and this is just the drivers that we use, to use the payment and delivery system as our target. We believe that changing the way you pay and the way the system is organized will make the most difference. There are other ways to do it. I'm not saying that's the only way. That is the way we've chosen to focus on how you pay and how it's delivered. And we focus on the full range. This goes to the full sort of PDSA cycle, really is that we do federal policy, we do state policy, we do regulations, we do guidance, we do contract arrangements between Medicaid and states. We do cross-sectional partnerships to see if they can do things. We're looking at TANF regulations right now and how TANF regulations and oral health and employment can all be wrapped up together. So it's not just Medicaid, it's not just at the state level, it's not just at the federal level. And then we are trying to get better at raising. I think in the last couple of years have done better at raising the visibility of oral health to other partners, and how do we partner on social media, on other platforms to really get oral health into other avenues. I have no idea where I'm pointing this. So here's a full cycle of change that I want to use, probably because Bert just went through where our success was in ACA, but there were a lot of compromises along the way, and we're still in this full cycle of change when it comes to dental care and ACA. So our concept is that we really need to expand dental coverage, and this was the opportunity to do it in the private market. We had spent a lot of time on CHIP and Medicaid, but here was the opportunity to change the private market and, like Bert said, correct some of the errors that we've made in public coverage. Like Bert said, we did start big. We walked in at a high water mark of saying oral health for everyone, compromised to go to pregnant women, and then we ended up with kids. So good, we're gonna use that. So the design was it was clear that there was using existing policy. How do you use existing policy? If kids are the existing policy, then let's use CHIP as the benchmark. It's already in statute. We'll use CHIP as a benchmark to get benefits to kids. That, for us, was a compromise of using the existing system. Instead of using the Medicaid concept of integrated and consumer-focused coverage, we decided to compromise and really preserve the existing insurance market by using sort of the benchmarks that we did. The other thing I want to point out is, because there's a ton of work being done on the Medicare side with a lot of different avenues, is that because life comes full circle in this town, there's really only 12 people in this town, is that, and I say that because I'm staring at Patrick again, is that many of the people in this room too were part of when Senator Bingaman wrote what he called a high watermark bill, which was led by Frederick Assassi, who is now the head of Families USA. How this comes full circle is he pulled together a large group, and we worked closely on legislative language for a high watermark bill for everyone in the country. And when ACA rolled around, I was even naive. I mean, Libby, who is our lobbyist, many of you know her, is way, way, way more sophisticated than I am. that was sitting there. It had been introduced a couple of times, but was sitting there after many, many meetings. When ACA came around, Frederick was so wise and said, let's just pull it all in. I was like, are you serious? Are we really gonna pull all that stuff? And he's like, yeah, we'll just pull it in. We got the language, we'll plop it in. And that's what we did. So all the work that's being done and all the times where there's bills introduced and they don't pass and they die and they sort of move on, like those are all exercises in moving something forward, because had there not been meeting after meeting after meeting to develop this high watermark bill, there was nothing to pull in. And that was done so efficiently. And there are the public education campaigns and CDC, there's some reporting requirements, it's sort of across the board, and they're spattered in the things that we don't really talk about in ACA, but things got funded all over the federal agencies because of that language. However, implementation continued, and that's where a lot of the hard work is. Not that getting it in place isn't hard, but that's one very small piece of this whole thing. We went to regulatory definitions. We failed on, we are still working on what we really want the benefit to be designed and how they define dental services. We did get consumer protections and some affordability, which we're still working on. But we did go to the states and helped numerous states. We helped multiple states set up what their benefit should look like in their marketplace for kids and try to influence the adults to pull them in as optional. And to this day, we still educate navigators. For those of you that know who navigators are, the people that keep getting defunded to help consumers actually get into marketplace coverage. We still have contracts to do navigator trainings in states so that they understand how to use their dental benefits. So in the evaluation, we've been monitoring enrollment in the consumer experience and monitoring the affordability. And what we have found is there's no data. And so data collection is one of our biggest targets for ACA, is there is almost no data on oral health. It's one of the things we overlooked, when we did this. It's one thing we desperately need to justify any changes that we have. So when we're looking at going back for fixes, which is not a popular thing to do, ACA fixes, but when you look at what we are asking for to correct some of our mistakes or to improve upon what we did, it's data collection. It's clear that the integration of dental benefits needs to be done because it's not working for families in the ACA to have separate benefits, and that we need to expand to adults because adults are clearly being left out of many markets. This is my second example, and then I will stop talking, is the importance of persistence, is that because we've been at the table and because we've been doing this for 22 years, that there is eventually movement. This is what actually gets me up in the morning now. It's because we've been doing this for 10 years. 10 years, we've been working on oral health for pregnant women in a bunch of different avenues. And it's a good thing that it happened this year. Otherwise, I would have been like, you guys are done, we're done. This can't get done. In 2005, we started with the American Academy of Pediatric Dentistry on trying to educate providers on sort of age 1 visit and doing CODA requirements for education about pregnant women in oral health. We moved into draft language for CHIPRA. So we've moved through the years. But my point is we've gone through multiple HRSA, thank you HRSA, whoever's from HRSA in the room, of sticking with us to try to build a system in states and at the federal level and with providers to really discuss the importance of oral health for pregnant women. We released a document in 2008 sort of challenging all of you in the room and all of our partners to why we can't get this past the finish line, why we can't get benefits, why we can't really address the oral health of pregnant women. And at the same time we were doing that is the rise of maternal mortality and sort of the face on sort of the disparities in maternal mortality. For the first time, we walked over to ACOG, the OBGYNs, after years of trying to work with them, and walked over to them and said, how can we help you with maternal mortality? We want to put some oral health language in the maternal mortality legislation. Oral health is part of the problem. What can we do to help support your bill? We now have 3 bills that have comprehensive benefits for pregnant women. One of them was dropped just this week. Cory Booker has some amazing language in how to expand Medicaid access for pregnant women that includes oral health and goes beyond just pregnancy. So not that any of these are in statute yet, but this takes a long time. I mean, this seems like a no-brainer to all of us in the room that you would give pregnant women access to dental care. It's like, you know, Mother Earth and apple pie, like, right? They're pregnant women. Like, this is, like, they're almost as beloved as kids. Not quite. But like 10 years that we've been trying to sort of push this at a significant level. So it's partially don't give up, but you do have to be at the table and you do have to offer support along the way to others when it doesn't feel like it's necessarily in your best interest.